Welcome to the session on TB and COVID-19, the two pandemics at the India TB Summit 2022. I'm Lancelot Pinto. I'm a consultant respirologist at the PD Hinduja in Mumbai, and I have the honor and privilege of co-chairing today's session. So, what do we intend to discuss over the next hour or so? When you talk about diseases, you talk about the epidemiological triad, the agent, the host, and the environment. And it's amazing how similar or the similarities that both COVID-19 and tuberculosis share, which therefore lends itself to common solutions, common pathways, and common ways of looking at the problem. So when you look at the agent, both the agents, whether it's the tuberculosis mycobacterium or it's the virus that causes COVID-19, both of them are airborne and therefore spread from person to person through the air, and therefore measures such as masking, measures such as distancing might play a role in prevention. When you look at the host, unfortunately, like most diseases, they tend to affect the vulnerable the most. Individuals who are elderly, individuals who have comorbidities, individuals who are impoverished, have poor nutrition, potentially have worse outcomes than individuals who don't have any of the above. And when you look at the environment, overcrowding, living in poverty, living in conditions which are subject to minimum distancing among individuals, all contribute to both the pandemics of tuberculosis as well as COVID-19. What we hope to achieve over the next hour or so is look at the challenges that different stakeholders play in the management of tuberculosis and COVID-19, how COVID-19 has affected the control of TB, the ambitious plans that we may have had for TB, and what are the opportunities, therefore, that we can look forward to. How has our understanding of the spread of an infectious virus helped our understanding of tuberculosis and how to manage it best in the future? How can we be better prepared for future pandemics or future viral clusters which may happen and take us and catch us off guard suddenly? So we begin with today's session with someone who represents the most important stakeholder and voice in either tuberculosis or the COVID-19 pandemic. And we speak about the patient, the individual going through the entire disease process, the entire infection, and therefore suffering as a result of the same. We have Ms. Bulbul Sharma, who will be speaking to us today. She is a content creator, a patient advocate, and a TB survivor. She will talk to us about challenges faced by patients during the pandemic and go through her own personal story of how she survived tuberculosis, the trials and tribulations that she had to go through to get cured of the illness, and how her work as a TB survivor, her work in helping individuals through the COVID-19 pandemic taught her some valuable lessons in terms of how we need to address this problem to best serve the most important stakeholder, who is the patient. We then have the second session by Professor Madhukar Pai. He's the Canada Research Chair in Transitional Epidemiology and Global Health, and the Associate Director of the McGill International TB Center. Dr. Pai has been at the forefront about speaking about the inequities associated with the care of tuberculosis, the problems that we face when it comes to quality standards, especially in the private healthcare, which is often unregulated, which is often expensive and inaccessible to the majority. He will be speaking to us on his topic today, which is from mismanagement of TB to mismanagement of COVID-19. How can we work towards improving private sector healthcare, in which he will speak about the challenges faced by patients in India when it comes to diagnostics, when it comes to treatment, when it comes to accessing the healthcare, and how these traditional problems faced because of when patients access care for tuberculosis were also faced during the COVID-19 pandemic, and how we need to look at consolidated pathways towards helping patients access care for both diseases. We will then have Dr. Jennifer Furin, who is an infectious disease clinician and anthropologist based at the Harvard Medical School in the Department of Global Health and Social Medicine in Boston. She has worked in the field of TB for more than 26 years, focusing on improving access to the best treatment for all forms of TB for vulnerable populations. When the COVID-19 pandemic hit in 2020, she founded and ran her hospital's COVID-19 service, receiving the hospital's Presidential Medal in recognition of her work on behalf of people affected by COVID-19. The thrust of her talk is that it's not just innovation that helps progress when it comes to disease, when it comes to public health. We know that vaccines and drugs have been innovated at a record-breaking pace when it comes to COVID-19, but these mean little if they are inaccessible to a majority of the world. She will also address stigma, psychological comorbidities, implementing community-based models, and integrating chronic care when it comes to the care of patients who suffer from long COVID and could potentially suffer from similar long-term sequelae of diseases such as tuberculosis. The final talk for today would be a talk by Dr. Rao. Dr. Rao is the DDAG TB of the Central TB Division of the Ministry of Health and Family Welfare in India. And he will speak to us about opportunities and how we need to be optimistic about the future, how the government acknowledges the challenges faced by patients with tuberculosis and COVID-19, and how it is working very hard to improve the care of such patients. He acknowledges the reduction in case notification rates for tuberculosis during the past 2 years and possible losses to follow up. And he will be speaking to us on opportunities to leverage the similarities of the two diseases, the two pandemics. He will speak to us about bi-directional screening, increased funding for tuberculosis, among other innovative ways in which we can address both these pandemics. His topic will be TB in the midst of COVID-19, a golden opportunity to strengthen public health care. I will then hand it over for the Q&A sessions to address all the questions from the audience. I will hand it over to Dr. Bornali Datta, who is my co-chair. She's the Director of Respiratory Medicine at Medanta, the Medicity Hospital. She has extensive experience in treating drug-resistant TB cases, as well as complex COVID-19 cases. She is herself a COVID-19 survivor. So I look forward to the next hour of very interesting debate and discussion related to the two pandemics and how we can move forward, helping patients suffer from either of the two diseases in the future. And I hand it over to the first speaker for today, Ms. Bulbul Sharma.
Hello, everyone. I'm Bulbul Sharma, and I'm a fellow with Survivors Against Tuberculosis. So today, I'm here to talk about the effects of COVID-19 on patients with tuberculosis. But before that, I'll take you through my long and arduous battle with TB. I was 23 when I was diagnosed with a non-pulmonary form of tuberculosis. I had TB in my head. While initially the biggest battle was with getting the right diagnosis, I had no idea about what was waiting for me. Side effects and the related stigma were possibly the biggest challenges for me to deal with. However, I still consider myself fortunate. Why? Because I was diagnosed and treated with TB in the pre-COVID times. So when I say I was fortunate and I was lucky, this is what I mean. Let us look at this WHO's 2020 report on the effects of pandemic on TB and patients and how the services were disrupted. So according to the report, TB deaths increased for the first time in a decade as far as 2020 was concerned. There was a 50% reduction in TB case detection in the same year. The report also estimates that 1.85 million deaths occurred due to TB globally in the year 2020. Now that we decently understand the magnitude, the effect, the great effect that the pandemic had over TB patients and TB services, let us understand the challenges that TB patients continued that the TB patients continue to face. Diagnosis and treatment. The challenge with regard to diagnosis involved and still involves doubts with respect to where to get the tests done, which tests to even go for, the interpretation of those reports, and the next steps. For the treatment, the biggest hurdles faced are treatment adherence, accessing treatment facilities, side effect management, and various others. Nutrition. Nutrition, which plays a major role in the causal chain of many diseases, is extremely important in the recovery of a TB patient. However, food insecurities were created due to the economic slowdown induced by COVID-19. This economic slowdown also affected direct benefit transfers to TB patients, which further crippled them. Mental health. Complete ignorance to mental health forced TB patients into the furthest corners. No proper counseling and follow-ups made the situation even worse. Inability to access services due to disruption in transport and due to the redirection of all healthcare support to managing COVID-19 were bigger problems too. Now, I would like to tell you that these challenges were inferred based on the data that was recorded by SATB's multilingual virtual help desk in the form of queries asked. The virtual help desk is running and continuously providing peer support and expert-led assistance to TB patients and their families. That we have understood the challenges well, let us look at the ways to combat them. Survivors recommends the following. Prioritize case detection, address treatment challenges, address mental health and stigma through peer support. Deploy strategic communications, both in the form of interpersonal communications and a media mix. Create and initiate accessible remote treatment support. There's an urgent need to kind of strengthen those remote treatment systems, or in fact, build them from the scratch, maybe. Create and emphasize community-based care. Engage private health services. It is very important that the private healthcare system now shoulders an equal responsibility with the government, with the government healthcare system, since the government healthcare system rarely crumbles under that kind of a pressure, especially in a high burden country such as India. Strengthen implementation of direct benefit transfers, such as Nikshay Poshan Yojana. Gender responsive care and solutions are equally important. We also need to tackle those infrastructural challenges. And I believe the use of local machinery is very important to do so. Improving interventions and strategies. We need more people-focused strategies and strategies that are derived out of data. Towards the end, I like to say that even though the pandemic has reversed the forward leaps that we had taken as a country to eliminate tuberculosis, it has also helped us understand the vulnerabilities and fragilities of our healthcare system. On the brighter side, however, it has taught us ways to strengthen it as well. I think and I believe that we are now more prepared than ever to tackle TB, which continues to remain an endemic in various parts of the country. Thank you.
Hi, in this session on TB and COVID-19, I will be specifically speaking about the issue of mismanagement or poor quality care in the private health sector. I think we all know that COVID mismanagement has been widespread in India during this pandemic. Polypharmacy, which is use of multiple different therapies at the same time, use of unproven therapies, convalescent plasma is a good example, irrational, unnecessary use of antimicrobials, including hydroxychloroquine, ivermectin, doxycycline, azithromycin, favipiravir, and so on and so forth, untested alternative treatments, unnecessary investigations such as CT scans, approval of drugs without adequate phase 3 trial evidence, abuse of steroids with all the complications around mucormycosis are all critically important examples that we have seen during this pandemic. In fact, during the Delta variant, we documented many state governments and central government guidelines, including all of these medicines, many of which were completely disproven to be of any value in COVID-19 management. And things were so bad that we, India COVID SOS, an international volunteer group, had to come up with these sorts of simple home care infographics on what to do, and also to discourage use of all of these useless therapies and potentially harmful therapies. And this infographic was translated and disseminated in more than 20 Indian languages. But irrational treatments, as we have seen for COVID, is not new at all in India, especially in the private health sector. It has been a long-standing concern with tuberculosis, dating back to some seminal work done by Dr. Mukund Uplekar and others, who documented hundreds of different TB prescriptions, and continued by Dr. Udwadia, Dr. Pinto, and others, who shows that these trends continue to be a problem in India as far as irrational treatments go for TB. And more recent work from our team, a large consortium, now conducted in 5 different countries, where we've used standardized patients or simulated patients or mystery clients. So when you have a patient actor presenting as a classic case of suspected TB, walking into the clinic with a history of 2 to 3 weeks of productive cough, fever, weight loss, loss of appetite, what happens to them when they visit various health sectors? And what we find here are the highlights of these studies in 5 countries. Across all countries, only about a third of these suspected TB mystery clients are correctly managed. Correctly managed means either a referral to the public program or any test for TB, including an X-ray, sputum smears, or gene expert. We find that only about a third are correctly managed. We find that public sector does ask more for sputum tests than the private health sector does. And we find that referrals are very uncommon. Most private providers prefer to manage patients. They do not like to refer. And polypharmacy that we saw so prominently during COVID-19 is dominant in tuberculosis. So when somebody presents with classic TB symptoms, the approach is to use broad spectrum therapies, multiple therapies, for once, twice, thrice before TB test is even done. And antibiotics are very, very widespread, including fluoroquinolones, sometimes steroids, and sometimes lots of unnamed pills are dispensed to people with suspected TB in India. And so the key issues as far as quality of TB care in India and in the private sector is low rates of TB testing by private providers, even when people present with very classic TB symptoms, low rates of referral to the National TB Program, empiric management with antibiotics and broad spectrum therapies, multiple rounds before TB is detected, and that results in long patient pathways and diagnostic delays. Chest X-ray is the preferred test, not sputum tests. Use of drug-resistant testing in the private sector is very low, and private health sector doesn't have much capacity to follow up, to look at adherence and treatment completion. And then the high cost of care in the private health sector is another important consideration. So some thoughts on how we can tackle mismanagement, either whether it's COVID or whether it's TB. I think these are critical considerations. One is India needs to come up with very strong national guidelines consistent with WHO and global guidelines. This happens for TB, but it hasn't happened for COVID-19. It's because the national guidelines have been inconsistent and have incorporated untested therapies that many states have also followed this. So a clear evidence-based national guideline is critical, and that must be updated when new evidence emerges. National guidelines must be followed consistently across all states in India. Each state cannot be prescribing its own cocktail of medicines. New drugs must not be approved without strong phase 3 trial data. That should be in the public domain. A better regulation of antibiotics is absolutely fundamental. Enforcement of the Schedule H1, for example. Right now, India's antibiotic consumption is just completely off the charts, and this can prove to be extremely challenging for antimicrobial resistance. Price controls and price caps are necessary to prevent the private health sector from price gouging and overcharging. There must be clear communication about rational practices via social media, newspapers, radio, and television. PPM projects, public-private mixed projects, can be extremely helpful to educate, incentivize private providers to improve quality of care. There must be clear institutional mechanisms to purchase services from the private health sector, and education right from medical students and residents on rational evidence-based care, careful use of antibiotics. All of that is absolutely necessary. And then, of course, for practicing doctors, ongoing CME programs and retraining is also quite critical. And I think for TB, we have plenty of pilot projects in India showing that we can work with the private sector. We can allow them to manage TB, but we can support them to notify, we can support them to do microbiological testing, we can support them to do adherence and treatment completion. With effort, it is possible to reduce mismanagement and improve quality of TB care. But my last point on which I will close is that if there is one lesson that India should take from COVID-19 and to build a healthier nation, and that is excessive reliance on the private health sector is simply not a good strategy. India must invest more in the public health sector and build a comprehensible, equitable health system that will serve all Indians, not just those who are rich enough to afford the private health sector. And all of you can download a copy of our book, Quality of TB Care. It's available free as a PDF, and we hope that you will find it useful as you think more about quality of TB care and strategies to improve quality of TB care. Thank you.
Hi, everyone. Good afternoon. My name is Dr. Jennifer Fern, and it's my pleasure to join you today via this Zoom recording at your India TB Summit in this session on COVID-19 and TB. Today, I'm going to be talking about how India can use the lessons learned from the COVID-19 pandemic to strengthen and build an equitable healthcare system for infectious diseases. And I'm primarily a tuberculosis doctor, so I'm mostly going to be talking about how to build an equitable healthcare system for tuberculosis, but I think the lessons definitely apply to other infectious diseases. Before I get started, I do just want to say that I hope everyone who's attending this conference is doing okay and that you and your loved ones have been all right during this incredibly difficult couple of years. I don't think any of us imagined that we would still be dealing with COVID-19 today. And so I'm certainly mindful that this has been a really tough 2 years for everybody. But I think it has been 2 years that give us some pause and some opportunities to think about where we can do things better. And certainly in the field of infectious diseases, and particularly when it comes to tuberculosis, we haven't done well for people living with the disease. And in fact, TB, more than any other disease I've ever worked with, seems to be very proud of being a tradition-based approach to disease. And while I think it's important in medicine to acknowledge tradition, we stand on the shoulders of the people who came before us. We have to acknowledge that that allows us to see further and change and innovate. And so we have to be able to innovate. And I think we're learning this the hard way in the TB space. And we know that the TB situation around the world has been markedly impacted by COVID-19 in a negative way. So I'm hoping today to share some thoughts on how we can use lessons learned during COVID-19 to improve the way that we take care of people who are impacted by TB. And then those lessons can apply to other infectious diseases as well. I think the first and one of the most important lessons is that rapid innovation is both necessary and possible to address infectious respiratory diseases. We saw that in COVID-19 where everything happened so quickly, but equitable access plans need to be developed and enforced from the beginning. With COVID, we really quickly got vaccines, rapid diagnostics, new therapeutics. But what we found is those were largely hoarded by wealthy countries or wealthy people. And there were no plans on equity or access. And if anything, COVID widened the health gap that often exists between resource-rich people and nations and those that are resource poor. But TB definitely needs to do more when it comes to innovating. We're starting to show some promise in innovation, but access is too slow or limited. And this includes things like cartridge-based nucleic acid amplification tests or GeneXpert or MolBio. Almost everybody should be diagnosed with TB in this way, and we should have rapid access to information on rifampin resistance, quinolone resistance, but sadly in many places in India, they're still relying on smear and culture, and this is not acceptable. We need to make sure there's better research around all oral shorter treatment regimens for drug susceptible and drug resistant TB, and that they're rolled out equitably. In India, it's really a shame that children are still getting injected, particularly younger children who have drug resistant TB, and this just isn't acceptable. And we also need shorter and better regimens that are accessible for prevention of TB for people who've been exposed. COVID-19 also taught us that facility-based models of care are really risky. And the risk comes both from transmission of infection within facilities, but also from the collapse or closure or even just repurposing of health facilities and facility staff. Community-based models of COVID-19 care were rapidly developed and deployed, but TB in many places still relies on routine interactions with the healthcare system, whether it's for DOT to give those nasty, horrible injections. And this was devastating for people living with TB disease who are given little to no support and essentially abandoned. We need to make sure that people don't have to go to facilities to take their treatment, that they can be educated and empowered to take their treatment at home or with support as they need, and that there's not a one-size-fits-all model. But we do know from COVID-19 that stigma around contagion is prominent and ongoing for both diseases, and it must be addressed. We know from COVID-19 that infectious respiratory diseases often affect the entire household, and they really require family-centered models of care. And the same is true for TB, the same is true for many infectious diseases, but by and large, we've failed both in COVID and in TB in coming forward with family-centered models of care. And in doing so, we really place household members at great risk. COVID-19 did a better job in terms of contact assessments and tracing systems. They were much more robust than TB, but we still need to address things like disclosure, stigma, different family members' roles, and psychosocial and socioeconomic support must be provided as part of these family-centered models of care. We know that when it comes to infectious diseases, multiplex diagnostic research and treatment platforms are both needed and possible in order to identify comorbidities and provide integrated care. And COVID-19 really revitalized this idea of platform trials to test multiple interventions with methods that can address changing standards of care. They introduced testing with a single specimen for multiple diseases. And then they risk stratified people based on comorbid disease and manage those comorbid diseases. TB really needs to learn from this and come around to using multiplex testing. And we have done some work on TB and HIV integration, but much more needs to be done around testing for multiple diseases with a single specimen, fostering innovation in study design, and providing holistic care for people living with the disease. And finally, we know that the long-term effects of even a short respiratory disease must be addressed. With COVID-19, we hear a lot about long COVID, right? So we know that even if the infectious pathogen is cleared and gone, that there can be lingering effects. And people talk a lot about long COVID syndrome, but TB programs seem to stop caring for and about people once they're given a final outcome. Once that TB is gone, it's not the problem of the TB program anymore. And there's little that's known or done to address long-term issues. And we absolutely have to change this. An infection may clear, but the person may still be living with the consequences of that infection for a very long time. And our systems need to take this into account. So TB has much to learn from the experience of COVID-19, and TB innovation is needed to make up lost ground. It's devastating to hear about the drop-offs in TB diagnoses that are being made. I work in South Africa. I'm seeing tons of families that are just being decimated by TB right now. So we have to do this, and it's not only possible, we did it with COVID-19, but it is our absolute imperative. So I just want to thank you for giving me time with my esteemed colleagues on this panel. My email address is here. If you want to talk more or have any additional questions, please don't hesitate to reach out. And thank you again to you all for all you're doing, and have a great rest of the day. Thank you.
Greetings from the Central TB Division and the Ministry of Health and Family Welfare, Government of India. And it's a pleasure to be part of the India TB Summit. And I'm Dr. Raghuram Rao. I'm a Joint Director in the Ministry of Health in the Central TB Division. Today, I would love to be speaking about how the government has, and the TB program has used, and there's a window of opportunity for the TB program, and how have we strengthened the public health care in the country. TB and COVID, being respiratory infections, have primarily attacking the lungs, and the pandemic has brought quite a few challenges to us with additional stigma and discriminatory behavior against people perceived to have been affected with these symptoms, and also for fear of being quarantined or diagnosed of TB or COVID. So the health seeking behavior has been severely impacted. You could see that with almost 25% reduction in TB case notification in 2019 in 2020 as compared to 2019, where we almost notified 24 lakh cases, and that reduced to almost 18 lakh cases. But you can see in the graph below that in 2021 we were a learned program. The public health infrastructure was a lot more capacitated to handle the response, and like you see during the peak that was there in 2020, where in the month of late March, early April, the nationwide lockdown was implemented, and a lot of restrictions due to control the COVID that had to be mandated. You'll see that the average notification per month, which was in 2019 around 200,000 or 2 lakh cases, reduced to almost 80,000 cases in the month of April in 2020, and then it took almost the year end to reach back to 2019 levels. And you'll see that in 2021, in spite of having a harsher epidemic with severe cases, almost 3 times the first wave, you'll see that the program was able to get back to pre-COVID levels in terms of monthly notifications as early as June, July, with the peak which happened in May. So you can clearly see that because of this impact, we reduced the gap, and we could notify as high as 21 lakh cases in 2021. The evidence that we have seen and the impact that we have seen on COVID and TB, what we could see is that COVID, active TB as well as latent TB is a risk factor for COVID, and it has an impact on the severity and rate of progression of COVID, and it has adverse impacts on the prognosis of TB as well as it leads to higher mortality. And COVID and TB both, since they have common risk factors, have common vulnerabilities for both of these diseases, and co-infected patients almost have a 3 times higher risk of mortality and adverse outcomes. In terms of impact and the mitigation strategies that we could adopt, which is going to help the TB program and the public health response in the long run, is the introduction of the policy of bi-directional screening, means looking for TB among COVID and ILI SARI cases, vice versa, looking for COVID and among the TB cases. And this has led to early detection of both TB and COVID in those co-infected cases, and having a better impact on the treatment outcomes. Also, because of COVID, the program had to come up with a rapid response plan which can mitigate the impact, including making sure that there is uninterrupted diagnostic services, and treatment is not interrupted because of want of access to drugs. And in fact, in the recent recommendations, based on all these evidences, active TB disease has been considered as a high risk factor for severe disease or mortality among COVID patients, and the guidance prescribes that if cough persists for more than 2 weeks after COVID, the patient should be investigated for tuberculosis. And accordingly, the program also post-COVID follow-up for TB cases, looking to these patients who have had COVID in the last 2 years, go back to them and screen them for tuberculosis every 6 months, and also in post-TB treatment follow-up for COVID or post-treatment sequelae at 6 monthly intervals. So these are the technical recommendations that we have incorporated into the national program. In terms of infra and public health strengthening, COVID era has taught us a lot. A lot of investments have happened in getting these molecular diagnostics. There was a time when COVID first came in 2020, and there was a sudden shortage of molecular diagnostics for doing COVID testing. RT-PCR machines were restricted to certain ICMR laboratories and NCDC laboratories, and the only program under the National Health Mission which had molecular diagnostics was the TB program, where we had GeneXpert or CBNAT and TrueNAT machines in the system, which was used for COVID testing at that point of time. And then slowly the country then invested into putting in systems for lab testing, and we now probably have RT-PCR labs in every district of the country, and there is so much of capacity in-house that in fact now initially we were a country which was importing technologies, and now we are exporting technologies. So there's a lot of investments and lab strengthening that has happened because of COVID that has a very direct impact on TB, and we have molecular diagnostics almost at the block levels, below district levels, and that will improve case finding, and it has expanded the molecular diagnostic network to over 5,000 laboratories in the country now, which is available for tuberculosis, and it's something which is going to help TB in the long run. Second important aspect of COVID that we have seen is that a lot of investments with additional, over and above the existing money, the impetus, financial impetus that health got, we invested that in improving the infrastructure and getting additional human resources and building capacity of the human resource to respond to critical care diseases and infections of communicable nature. And so now you will under the upcoming things in PM ABEAM and in the emergency COVID response packages that have been given, a lot of investments have happened to develop integrated public health labs at the district level, at the block level, critical care units at the district level. A lot of ICU capacity, oxygen beds capacity has been increased, and all these things are going to help tuberculosis and such diseases of respiratory health and communicable disease, where infectious disease wards are established. Diagnostic capacity to test it at decentralized levels is available now, and in public health surveillance, TB is very cleanly looked at now. Everybody knows what is contact screening, what is quarantine, what is isolation, what is self-isolation in the home, and the platform technologies and all those things that have happened is translating into looking for TB in every home visits or household level or outreach activities that happens. So that's going to help us in finding TB in the long run. One very important aspect of public health that we have seen is airborne infection control, which was a dream for tuberculosis program, which was always required, but the larger health system had to take it up. And with COVID now, you'll see that there are cough corners in the hospitals, there are isolation rooms, there is triaging of patients with cough, and ruling out infections, communicable diseases before being taken for surgeries. So a lot of airborne infection controls has been incorporated and established in the public health settings. Apart from that, in the community level, the COVID appropriate behavior and the community behavior of using mask, of social distancing, of physical distancing, ban in spitting in public places, all those things are all something which we always aspired for tuberculosis, and that is something which is now available for us, and it's something which we have to invest in and sustain that going forward in the in the next few years, and that will definitely have an impact on TB transmission. newer technologies, AI-based tools, X-rays, point-of-care tests, and telemedicine, teleradiology. So many newer technologies have come in, which are now being, going to help TB in the long run, and is now made available across the public health system and at decentralized levels, even going down to the health and wellness center, at the sub-health center, at the primary care level. So all these opportunities, which are because of COVID have been made available, is something which is going to help tuberculosis in the long run. So this is in a nutshell what I wanted to share about TB and COVID, and the way it has helped us strengthening the National TB Elimination Program to achieve our targets of ending TB by 2025. Thank you.
What an all-encompassing and enlightening discussion with so much of food for thought. The way forward needs to acknowledge the difficulties faced by patients. We need to always remember that the patient is the center of the healthcare model, and listening to the trials and tribulations that our patients face, listening to their concerns and addressing them by focusing on a community-based treatment model becomes extremely important to address concerns, to address the challenges faced by patients. It's also important to think of bi-directional screening such that we create a framework which could then be applicable to any respiratory illness in the future, any transmissible respiratory illness, not just COVID-19, where we have a model in which patients with tuberculosis can get screened for other viruses when the need arises, and vice versa. When individuals come with any acute respiratory illness, they are asked questions thinking about whether they could potentially have tuberculosis, and then screening them for TB as well. I think it's important, this is an important time for us to talk about preventive measures. I think very little attention has been paid on ventilation in India, and we now acknowledge the fact that ventilation has an extremely important role to prevent the spread of COVID-19. And it has been known for some time that ventilation and close contact play an important role in the spread of TB as well. I think this is an important time to open the conversation around what we can do best to ventilate indoor structures better, and thereby prevent the spread of diseases in places such as schools, in workplaces, in closed, crowded places where spread becomes so easy. I think it's important to normalize masking as well, especially when individuals are ill, when individuals have a cough, when individuals have a respiratory tract infection, to encourage individuals to wear masks and normalize it in a way, in fact, even encourage it and applaud individuals who wear masks when they are unwell themselves. And I think these would be great public health measures for the future. We also need to think about the private health sector, which has always been problematic when it comes to adhering to treatment guidelines, when it comes to quality of healthcare, when it comes to, especially when it comes to tuberculosis. And we've seen the same spill over to COVID-19 as well. I think it's important to address the quality of care with standardized guidelines across the country, and then help implementation of these guidelines at the ground level by dissemination of education. I think last but not least, it's extremely important to focus on psychological care and the stigma associated with transmissible infections. We've seen this in the past with tuberculosis. We saw it during COVID-19 as well. There was a lot of stigma that individuals had to overcome. And I think the best antidote to stigma is very often education. And I think we need to do our best to disseminate education to prevent such stigma. I thank you for a patient listening, and I hand it over to Dr. Barnali Datta, my co-chair, to take over the Q&A and discussions. Thank you.